Delayed puberty, a disorder in timing?
Christy Parker,
PGY2 Pediatrics. December 4, 2009. CanMed's Objectives Medical Expert.
1.
Outline the normal physiology, progression, and timing of pubertal development. 2. Delineate causes of delayed puberty in both the male and female. 3. Explain how to differentiate between constitutional delay and other causes of delayed puberty. Manager. 1. Outline appropriate investigations for male and female patients with delayed puberty, assessment of puberty history parents. Important to ask about onset of puberty in parents. Menarche, more reliable in mothers as they remember onset. Male growth spurt, as most fathers recall their pubertal progression more vaguely. Age of first shaving regularly. Parental heights, identify mid-parental height. Late bloomer versus early bloomer. Body changes, important to ask about each. Thelarche, galactorrhea. Adrenarche/pubarche, body odor, axillary and pubic hair, acne. Menarche. Gonadarche, history content, important to include. Past medical history, history of brain tumor, radiation, chemotherapy, known genetic disorder, chronic disease affecting growth. Eating habits. Any evidence of disordered eating. Activity level. Is exercise excessive or is this an athlete with a high level of training? Growth history. Previous growth chart can be extremely helpful. History review of systems. SNES, visual changes/visual field abnormalities, headaches, anosmia. Cardiac, congenital anomaly. Respiratory, asthma. Renal. GI, diarrhea, blood in stools. Physical examination of growth. Height. Weight. Head circumference. Upper to lower segment ratios. Pubertal assessment, Tanner staging. Axillary hair. Pubic hair and staging. Breast development and staging. Genital development and staging. Neurological assessment. CPS position statement on growth measurement. Tanner staging of puberty in males. Tanner. Prepubertal, testicular volume less than 3.5 milliliters, small penis of 3 centimeters or less, typically age 9 and younger. Tanner 2. Testicular volume between 1.6 and 6 milliliters, skin on scrotum thins, reddens and enlarges, penis length unchanged, 9 to 11. Tanner 3. Testicular volume between 6 and 12 milliliters, scrotum enlarges further, penis begins to lengthen to about 6 centimeters, 11 to 12.5. Tanner 4. Testicular volume between 12 and 20 milliliters, scrotum enlarges further and darkens, penis increases in length to 10 centimeters and circumference, 12.5 to 14. Tanner V. Testicular volume greater than 20 milliliters, adult scrotum and penis of 15 centimeters in length, 14 plus. Tanner pubic staging pubic hair, both male and female, Tanner I. No pubic hair at all, prepubertal dominant state, typically age 10 and younger. Tanner 2. Small amount of long, downy hair with slight pigmentation at the base of the penis and scrotum, males, or on the labia majora, females, 10 to 11.5. Tanner 3. Hair becomes more coarse and curly, and begins to extend laterally, 11.5 to 13. Tanner 4. Adult-like hair quality, extending across pubis but sparing medial thighs, 13 to 15. Tanner V. Hair extends to medial surface of the thighs, 15 plus. Tanner breast development. Breasts, female. Tanner I. No glandular tissue, areola follows the skin contours of the chest, Prepubertal, typically age 10 and younger. Tanner 2. Breast bud forms, with small area of surrounding glandular tissue, areola begins to widen, 10 to 11.5. Tanner 3. Breast begins to become more elevated, and extends beyond the borders of the areola, which continues to widen but remains in contour with surrounding breast, 11.5 to 13. Tanner 4. Increased breast size and elevation, areola and papilla form a secondary mound projecting from the contour of the surrounding breast, 13 to 15. Tanner V. Breast reaches final adult size, areola returns to contour of the surrounding breast, with a projecting central papilla, 15 plus. Normal pubertal physiology. HPG axis, hypothalamic pituitary gonadal, is essential in turning on puberty at appropriate times. Pulsatile secretion of GnRH is essential. GnRH is produced in hypothalamus, in arcuate nucleus. GnRH travels to the anterior pituitary to stimulate the production of LH and FSH. Normal pubertal physiology. HPG axis is active in the first few weeks of life. LH and FSH rise as HCG from placenta is gone. This results because the fetoplacental unit acts to produce negative feedback on the HPG axis during late gestation. HPG axis usually quiescent during childhood. Result of negative feedback on the hypothalamus. Axis re-stimulated during adolescence. Stimulation results in a positive feedback loop. Estrogen from maturing follicles stimulates LH surge for ovulation. Pulsatile release of hormone increases overnight first. This eventually progresses to secretion during day and night. LH can be detected in pulsatile forms. FSH has longer half-life, so pulse is not as evident. Menarche does not signal full maturation of HPG axis, may simply be withdrawal bleeding from progesterone, greater than cycle takes longer to become ovulatory. Role of gonadotropins FSH-LH. Stimulates androstenedione by the ovary. Involved in spermatogenesis in the testes. Induces receptors for LH. LH. Uses androstenedione for substrate to produce estradiol cells. Stimulates testosterone synthesis by Leydig cells. FSH is usually higher than LH in prepubertal stages, and this reverses in pubertal stages. Age of pubertal progression. Females. Thelarchy. Generally considered the onset of puberty. Occurs in most girls at 9.5 to 10.4. Menarche. Mean age of onset equals 12 years. Adrenarche. Usual onset at approx age 9.4 to 10.6 years. Linear growth. Generally occurs before Tanner stage 2 breast development. Generally adds 20 to 25 centimeters of height in females. GH increases during puberty as well, provides 50% of growth spurt. Nhanes 3 dates. Are females entering puberty earlier? Onset of puberty earlier, but completion has not changed. Differences between ethnic groups? Related to environmental factors or food additives? Related to better nutritional status, increased body mass/adiposity. Pubertal progression males gonadarchy, thelarchy, pubarchy, linear growth. Testicular enlargement generally heralds the onset of puberty, testes greater than 4 milliliters. This usually starts around 10.8 to 11.1 years. Initial increases in testicular size are due to increase in sertili, supporting cells. Average time to complete genital development equals 3 years. Thelarchy. 2/3 of males will have gynecomastia develop during puberty, mid-pubertal. Gynecomastia results from direct testicular secretion of estrogen as well as peripheral conversion of prohormones to estrogen. Pubarchy. Linear growth. Peak growth generally occurs after Tanner stage 5. Generally adds 25 to 30 centimeters in height for males. Pubertal milestones: females, males, Tanner stage 2, breasts. Testicular growth. Tanner stage 2, pubic hair. Tanner 2, genital development. Peak linear growth. Greatest weight gain. Tanner stage 3, genital. Tanner stage 3, breast. Tanner stage 3, pubic hair. Axillary hair growth. Acne. Onset of pubertal gynecomastia. Menarche. Axillary hair. Tanner stage 4, breast. Voice pitch changes. Tanner stage 4, pubic hair. Tanner stage 5, breast. Spermash. Regular menstrual cycles. Tanner stage 4, genital. Tanner stage 5, pubic hair. Tanner stage 5, genital. http://psychnet. APA. org/journal/bool/110/1/110_1_1_47_fig2a http://psychnet.apa.org/journal/bool/110/1/110/bool_147_fig2a.gif. Roll of bone age. Comparing radiographs of hand and wrist to reference standards. Female skeletal maturity is generally 2 years advanced as compared to males. Pubertal events more correlated with bone age than chronological age. Psychological effects. Puberty occurs during adolescence, during time of identity formation. Period of increased physical changes. When teens are behind their peers in terms of development, can lead to substantial teasing/bullying and self-esteem issues. Jameson, J.L. Rites of Passage Through Puberty, A Complex Genetic Ensemble. NAS. October 30, 2007. Volume 104, Number 44. NR0B1 gene is involved in development and function of the adrenal gland and HPG axis for gonadotropin secretion. GPR54 gene mutations affect GnRH release. These patients do respond to exogenous GnRH. PROP1 mutations lead to problems in differentiation of gonadotropic, somatotropic, lactotropic and thyrotropic cells. Pubertal delay. Based on statistical norms, greater than 2 from the population mean. Pubertal delay is most often seen in males. Present far more often than females, as delay causes more significant psychosocial implications. Most commonly no pathology present. Timing of puberty: consider pubertal delay if no breast development by age 13 in a female, no menses by age 15 in a female, testicular size less than 2.5 centimeters or 4 milliliters, or pubic hair is not present by age 14 in a male. Consider precocious puberty if breast development before age 8 or menarche before age 10 in females. Testes volume greater than 3 milliliters before 9 years. Pubic hair development before 8 years in females, and 9 years in males. Pubertal delay: hypogonadotropic, hypogonadism. Hypogonadotropic. Hypogonadism. Eugonadotropic. Hypogonadism. Low FSH, LH. Low sex steroids. High FSH, LH. Low sex steroids. Normal FSH, LH. Pubertal delay. Sedlmayr et al. Identified in their study that delayed puberty in men could be classified as constitutional delay of growth and puberty in 63%. Delay associated with underlying medical condition 20%. Hypogonadotropic hypogonadism 9%. Hypogonadotropic hypogonadism 7%. Hypogonadotropic hypogonadism. Constitutional delay of puberty. Malnutrition. Excessive exercise. Growth hormone deficiency. Isolated gonadotropin deficiency. Endocrine causes. Miscellaneous syndrome complexes. Brain tumors. Craniopharyngioma, astrocytomas, gliomas, histiocytosis sex, germinomas, prolactinomas. Iron overload, pituitary damage. GnRH receptor abnormalities. Constitutional delay of puberty. Most common cause of pubertal delay. Delayed puberty often found in siblings or parents. Diagnosis of exclusion. Bone age is delayed and consistent with degree of pubertal maturation, usually delayed by 2 years or more. Often associated with constitutional short stature. Constitutional delay of puberty counted. Progressive height gain, but along lower limits of normal, contrast to isolated gonadotropin deficiency which is normal growth, but no pubertal growth spurt. Early morning testosterone levels greater than 0.7 mol/L predict puberty within 15 months, Wu et al. Constitutional delay of puberty counted. Differentiated by pathological gonadotropin deficiency by observation over time, no definitive test available. GnRH stimulation test occasionally used, but not conclusive. HPG axis responds to GnRH more strongly if it has already been exposed to this, reflects previous stimulation. HCG stimulation test can also be undertaken, DeGros et al. Stimulated testosterone less than 3 mol/L suggestive of hypogonadotropic hypogonadism. Stimulated testosterone greater than 9 mol/L suggestive of CDGP. Kallmann syndrome, a syndrome of isolated gonadotropin deficiency. 1/10,000th males, 1/50,000 females. Present with anosmia or hyposmia. Can be difficult to differentiate from constitutional delay. Cal1 gene encodes protein, anosmin, required for GnRH neurons to migrate from olfactory placode to cribriform plate. Can also be associated with hair lip, cleft palate, and congenital deafness. Idiopathic hypogonadotropic hypogonadism. Males often have unicoid body proportions, upper to lower segment ratio of less than 1. Can be sporadic or familial. Can be related to problems in the receptor for GnRH. Can present as infant with micropenis and cryptorchidism. These infants will not show normal gonadotropin increase in the first few weeks of life. Excessive exercise. Questions as to whether lack of puberty related to low body weight or more as a direct effect of exercise. Interruption of training in ballet dancers, runners, syndromes associated with pubertal delay. Prader-Willi syndrome. Lawrence-Moon syndrome. Septo-optic dysplasia. Bardet-Biedl syndrome, panhypopituitarism. Pubertal delay is usually not presentation, present with short stature earlier. What controls the timing of puberty? An update on progress from genetic investigations, current opinion in endocrinology, 2009. Hypogonadotropic hypogonadism. Gonadal damage secondary to chemotherapy/radiation. Enzyme defects in the gonads. Androgen insensitivity. Ovarian/testicular dysgenesis, causes of gonadal failure. Gonadal failure, bilateral. In these cases, circulating levels of LH and FSH are high, hypogonadotropic hypogonadism. Congenital. Turner syndrome. Klinefelter syndrome. Complete androgen insensitivity. Acquired. Chemotherapy/radiation/surgery. Post-infectious, EA. Mumps orchitis, coccicuvirus infection, dengue, shigella, malaria, varicella. Testicular torsion. Autoimmune/metabolic, autoimmune polyglandular syndromes. Vanishing testes syndrome. Resistant ovary syndrome, gonadotropin receptor problems. Klinefelter syndrome. 45 XY most common, 2/3, remainder a mosaic or variant. Many affected boys will not be identified until adolescence when puberty is delayed. Some pubertal development, but testes eventually become fibrotic. Timing relates to degree of mosaicism in the patient. Small testicles and gynecomastia. Also often small phallus size. 90 to 100% are infertile. More female type fat distribution. Tall in childhood, with eukaryoid body habitus. Have fathered children, particularly those with mosaicism. Turner syndrome 45 exogenotype most common. Associated with short stature, variable degrees of puberty, primary amenorrhea and multiple congenital anomalies. Often presenting complaint is short stature, but in others, may present with delayed puberty. Most of primary ovarian failure. 50% of patients have some breast development, some axillary/pubic hair is typical for most patients. Associated with SHOX mutations which cause the short stature. Turner syndrome conted. Residual ovarian function can cause breast development in 15 to 25%, menarche in 5 to 10% and pregnancy in 1 to 3%. Receptor defects. LH gene defects and FSH gene defects can result in high levels of FSH and LH with low sex steroids. Secondary sex characteristics are driven by LH effects, can have FSH receptor defect and normal secondary sex characteristics, eugonadotropic pubertal delay. Congenital anatomic anomalies. Imperforate hymen. Vaginal atresia. Vaginal aplasia. COS. Hyperprolactinemia. In this case, secondary sex characteristics are normal. May have cyclic lower abdominal pain. Chronic illness can affect underlying genetic potential. May limit adequate nutrition, e.a. inflammatory bowel disease, cystic fibrosis. May be associated with glucocorticoid use, chemotherapy or radiation. Other endocrine causes. Hypothyroidism. Interferes with gonadotropin secretion, affects pulsatile secretion of LH. Hyperprolactinemia. Interfere with gonadotropin production. Prolactinomas may not always be visible on imaging. Investigating delayed puberty. Investigations depend on clinical presentation, but may include bone age, hormone levels, IGF-1, FSH, LH, estradiol, testosterone, YAS, prolactin, TSH. Karyotype. Hormone stimulation tests. RH stimulation test. GH stimulation test. Imaging. MRI if gonadotropin's high and no obvious cause of hypogonadotropic hypogonadism. Psychological distress and pubertal delay. Much has been written about psychological distress in males with delayed puberty. Self-esteem and sexuality in girls with Turner syndrome has been studied. Generally had low self-esteem scores, general and social. Lifetime sexual experience associated with overall SAE score. Increasing sexual experience had no effect, all or none phenomenon. Ross et al., greater than initiation of estrogen therapy associated with increased self-esteem in girls with Turner syndrome. Psychosocial adjustment in Turner syndrome. Journal of Clinical and Endocrinological Metabolism, 2006. Stimulating puberty in males. Should be begun at 12 years of age. Multiple indications. For CDGP. Indicated in those boys with psychological distress, who have poor body image, low self-esteem, are becoming socially withdrawn, or are subjected to teasing or bullying. Time of therapy initiation may vary, if GH deficiency present, delay starting to optimize height achievement. Testosterone supplementation may help with bone mineral density. Exogenous testosterone does not increase testicular size. Normal puberty continues to progress. Causes viralization, increased phallic size and scrotal rugae. Accelerates development of secondary sex characteristics to avoid psychosocial complications. Should be used only if burn age is delayed, and introduced at approximately normal time of development. Also stimulates growth spurt. Side effects: local discomfort at site of injection, priapism, androgen supplementation. Testosterone IM injections. Once puberty has begun, doses of 50 to 200 mg IM using testosterone esters have been used for periods of 6 to 12 months. Depot testosterone like this results in high testosterone peaks and a duration of action of 2 to 3 weeks. Theoretic advantage for negative feedback on HPG axis to be alleviated with wearing off of exogenous testosterone. Oral. Associated with more gradual effects. Testosterone undecano 840 mg poke daily. Oxandrolone 2.5 mg poke daily. Gels, transdermal patches, etc. have not been studied as well in boys and dosing is less predictable. HCG can also used to stimulate development of secondary sexual characteristics. Increases testicular size. Can be used to stimulate fertility. 200 to 500 units cold days. Stimulating puberty in females. Estrogen replacement. Increased gradually to adult replacement levels, as puberty is normally a slow process. Aims: attainment of secondary sexual characteristics. Attainment of menses. Stimulation of pubertal growth spurt. Acquisition of bone mineral mass. Uterine development. Estrogen replacement in females. Initiate replacement at age 10 to 12 years and should continue over course of normal puberty, approximately 3 years. Effect of estrogen on growth plate is dose dependent. Higher doses stimulate epiphyseal growth plate closure. Once dose of 10 to 15 micrograms of ethinyl estradiol has been reached, breakthrough bleeding becomes apparent. Once this occurs, progesterone should be added on a cyclic basis to prevent endometrial hyperplasia. Dosing: 0.3 mg conjugated estrogen daily. 5 micrograms of ethinyl estradiol daily. Transdermal estrogen 25 micrograms twice weekly. Increase Q6 12 months until maximum 20 micrograms. Suggested dosing increments: ethinyl estradiol 2 micrograms/day x 6 months. 4 micrograms/day x 6 months. 6 micrograms/day x 6 months. 10 micrograms/day x 6 months. 15 micrograms/day x 6 months. 17 estradiol 5 micrograms/depot. 10 micrograms/depot. 15 micrograms/depot. 20 micrograms/depot. Introduce progesterone once breakthrough bleeding has occurred. After this point can switch to an oral contraceptive pill. Estrogen side effects: thromboembolism, endothelial dysfunction, hyperlipidemia, increased risk of breast and gynecological malignancy, increased risk of gallstones. Achieving fertility may require pulses of GnRH in females. HCG in males 1 to 2 times/week helps to maintain spermatogenesis. 1,200 to 5,000 IU HCG IM 3 times weekly. 12.5 to 150 hmg IM 3 times weekly.